Hello and welcome to the program. We thank you very much for joining us today. I'm Pablo Sanchez, the Surgical Director of the Lung Transplant Program at the University of Pittsburgh. We are excited to bring you today programs, donor lung management from the ICU onwards. My co-moderator today is Julien Fessler. He's an anesthesiologist and a pain management specialist from Foch Lung Transplant Program Group in Paris, France. We would like to begin by acknowledging and thanking our partner-level supporter, Theratos Institute. This webinar is possible through this generous support. Organ preservation starts in the donor ICU, and the donor organ journey can impact significantly recipient outcomes. Intensive care clinicians commit to providing the highest number of donor organs in the best possible conditions through the optimization of donor physiology. The webinar today will discuss strategies for donor organ optimization prior to organ retrieval and consider the role for centralized donor management. Regulatory, legal, and ethical barriers to deceased donor organ intervention will also be explored. At the end of the presentations, there will be a question and answer panel with the faculty. It is my pleasure to introduce our first speaker, Jennifer Baxter. She's the lead nurse retrieval, a lead donor care physiologist transplant from the Royal Patford Hospital, NHS Foundation Trust, Cambridge, United Kingdom. Jennifer, welcome to the program.
Thank you very much. Thank you for the introduction and giving me the opportunity to talk a bit about our role as nurses at Papworth. I will just share my screen. I hope you can see all of that okay. So yes, I'm just going to give a bit of a run through really of how we work at Papworth with the nursing team and how we have moved forward with the donor care physiologist role over time and how we optimize our donors on the ICU prior to the retrieval team being mobilized. So first of all, the DCP role. So it's about keeping donor organs in the optimum condition throughout the retrieval process. We are trained in donor management specifically. So when we go out for our retrievals, we don't need to necessarily have an anaesthetist from the local hospital to attend. We are able to take that role on ourselves throughout the retrieval process. So we maintain the mechanical ventilation and hemodynamic stability throughout the retrievals. We're able to insert all of our intravenous and arterial lines as necessary, float the PA catheter and perform hemodynamic measurements throughout the retrieval process. We can complete and hand on the information from a transesophageal echo, a bronchoscopy. We've more recently introduced a lung ultrasound study at Papworth as well, so we're starting to do that for our retrievals. We undertake the airway management. Mainly this is in our DCD cohort where we're able to retube. We take all our own medications and drugs and are able to facilitate these along with fluids according to our DCP protocol throughout the retrieval process. So on top of that, for the retrieval process, we've also been taking part in a scouting service. So with this, we attend the ICU prior to the retrieval team arriving. So the specialist nurse for organ donation will give us a call and give us the details once they have the consent from the coroner and from the family to proceed. They will give us a call. We will be able to go through the details over the phone and see if it's feasible for us to attend and try and optimize prior to the donor going to theatre and prior to the offer going out to all the recipient centres. So we can attend within a certain travel distance. We had to have a bit of a range on this, but the idea is that we potentially optimize our donor organs, giving the additional information to the recipient centres when they're making their decisions for organ acceptance or decline. We're very much a one-man band. We go on our own. It's a non-medic service. We attend and take all of our own kit, equipment, medications, everything with us, and turn up on the ITU and try and optimize these organs to be the best they can be. So sometimes we have opportunities that arise that we wouldn't be able to attend. If the donor is quite far away, then we have to have a bit of a cut-off, the threshold for that. And in some instances, telephone advice is sufficient. They just want a bit of advice over the phone, and we're more than happy to do that. So we have a telephone advice line as well. The cost-saving implications for this also to come into consideration. It's a non-medic scout service. In some instances, the scout results may indicate that the organs may not be transplantable, in which case that would stop us having to mobilise our whole cardiothoracic retrieval team. Like I say, we go on our own, so it's very much a DCP-led service for this one, and can be a very valuable resource for the NORS team. So scouting episodes, so this was one that we went on recently where we were advised of a 56-year-old female who was on high inotropic support of NORAD, also on an ABG. Her PO2 on 100%, her PO2 was 24. So we went along to this scout, went to see this lady, worked very hard to get the NORAD off, changing things around with that. We also, as we arrived, we asked for a chest X-ray to be completed for when we arrived. Did another ABG, which showed a PO2 of 25 at that time. The recruitment manoeuvres were completed as per lung donor management protocol. We completed a bronchoscopy, managed to suction some very thick secretions successfully. On transducing the CVP, once we'd inserted all of our lines, the CVP was 14, so we gave some frusemide. Gave it a bit of time. In the meantime, we were changing other things around and trying to optimize things to be the best they can be. The CVP was reduced, came down to 8. So post-recruitment and bronchoscopy, did another ABG on 100%, and the PO2 had risen to 38. Another bronchoscopy was completed just to confirm that there was no reaccumulation of the secretions, which there wasn't. And this was a successful retrieval of bilateral lungs. They were accepted by a recipient centre and successfully transplanted. The heart was also transplanted as well from this particular donor, and it was all very successfully done. And what this does is this gives obviously the opportunity for all of this information, this added information, to be able to be given to the recipient centres ahead of time when they're doing their decision-making process. So there's persuasive evidence to suggest that the number of cardiothoracic organs could be significantly increased by early intervention of invasive hemodynamic monitoring, lung recruitment, and protective ventilation support. NHSBT identify that staff at donor hospitals can face many practical obstacles in initiating and sustaining donor optimization therapies, and the knock-on effect can adversely impact upon the number of hearts and lungs retrieved from donors following brain death. So by us being trained in this specific role, and we can go ahead of time and try and optimize things to be the best they can be following the donor protocol, can be very successful in particularly in turning around marginal organs. So the solution to being able to turn around these marginal organs is very much the scouting process. I'm a huge advocate of this and do believe that it really does work, being able to get ahead of time and be able to get to the ITU and be able to try and optimize these organs. A scout request can usually consist of anything between sort of 6 and 10 hours with the donor. And every hospital that we go to are always very, very grateful of the help and the input that we can do and to be able to facilitate this amazing gift from these donors. So that's just a little bit of an overview of what we do from a nurse-led scouting service at Royal Papworth. So thank you very much for your time.
Thank you so very much, Jennifer. That was it. Thank you for sharing your experience. I had to briefly remember what kilopascals to millimeter mercury is. So just it's 7.5. So that was a great improvement there on your PO2s. Thank you.
Yes, successful.
Yeah, very successful. Well, the one remark there, as you hear from our speakers, we encourage you to submit questions during the program. I would like to introduce our next speaker so we can keep with times. Is Dr. Are Holm. He's an associate professor and the head of respiratory medicine department at Oslo University Hospital in Oslo, Norway. Dr. Holm, thank you very much for being with us today.
I'll just let me pull this up. Yeah. Oh. So, sorry about this. So I want to thank the organizers for inviting me to speak at this webinar, and I thank you all for logging in. I'd like to start by showing this picture of Saint Damien and Saint Costas, who in the 3rd century performed the miracle of transplanting a leg from an African donor, as you can see. And this was, of course, considered a great miracle. And we should notice that instead of just healing the cancerous leg, the miracle was considered even greater because the two saints used a body part from a deceased human being to perform the healing. So we are actually using parts of a dead human body to heal another. And it is truly a miracle and a spectacular potential for doing good. But it also provides us a spectacular potential for doing harm. The question is, how do we navigate and how do we maintain the trust in transplant medicine? And my 10 minutes talk is going to outline some of the questions here. And the most central questions here is, what is the definition of death? And how can we interfere with a dead human body? Now, let us first look at the definition of death. And to understand it in the transplant context, I find it helpful to see death not as an event, but as a process. And I try to illustrate this by this drawing. First, at some point, you foresee death. You can see that it's unavoidable. And then there may be circulatory arrest with seized circulation, which after some time inevitably will lead to a permanently or irreversibly seized brain function. Now, the circulatory arrest may also come after the brain damage, of course, as I've tried to show here on this drawing. And then after a given amount of time, the other organs will lose function and die. And it is precisely this interval between the determination of the individual's death and the organ death. This is the window of opportunity for organ transplant. And the fact that modern intensive care can manipulate the timing of these events complicates things further. So let's look at the laws and regulations. The WHO updated in 2017 the criteria for death. And it's noteworthy that they use the terms cardiocirculatory arrest and neurological arrest. These two terms are used while there's only one kind of death. The first country to introduce the legal concept of brain death was Finland in 1971. And then in 1981, the Universal Determination of Death Act was passed in the United States and ratified in most states. And just as a curiosity, I would like to mention that there are national variants to this definition. In Germany, for instance, autoresuscitation of the brain is considered possible indefinitely after circulatory arrest. And for instance, in my country, radiological evidence of seized cerebral circulation is a requirement before organ donation. And I'm sure there are other peculiarities in different countries. What about the question of interference with the dead body? Regarding the procurement of organs, once death is declared, there are different views on how to decide this. Who actually owns a dead body? Is it the dead person who is no longer a legal subject? Or is it the next of kin or society? There has been a lot of discussion about opt-in or opt-out systems, but there are several publications showing that there's actually no difference in the actual consent rate between the systems. Let us now look at theological or religious views on the definitions of death and interference with the dead body. In the right corner, in the lower right, you see a series of references in case you're interested. Now, in Christendom, there seems to be no controversies with the definition of death or the removal of organs for transplant. And it's even said that the previous Pope, Ratzinger, had a donor card. In Islam, it seems to be slightly more complicated. And although donation is approved by many Islamic scholars, some have reservations against removing organs from a dead body. And the same may be the case in some Orthodox Jewish groups. And among some, there's also a strict definition of death as cessation of circulation, which makes transplantation difficult. In Hinduism, however, both the definition of death and the organ procurement are unproblematic, possibly related to the belief in reincarnation. Among certain Eastern Asian groups of Buddhism, there is a taboo against removing organs after death, and this may explain low donation rates in some countries in Eastern Asia. Shintoism is a particular phenomenon where there are such taboos regarding the dead. There are many taboos regarding dead, and this seems to be related to the low donation rates in Japan. But on this slide, I also want to show you this study by Goldberg and co-workers published in 2019. This is OPTN data from the United States showing the consent rates and the differences between consent rates between different groups in the population. And you can see that among the white population, there is 77% consent, whereas the lowest consent rate is in the Asian population in this study. And I show this on the same slide because maybe in some European countries, we may think that the lower consent rates in some groups may be related to religion, but maybe they are more related to social status of the group. The classical ethical considerations have been reflected, related to these two 18th century philosophers. Immanuel Kant, who held that a human should never be means to a purpose, and Jeremy Bentham, who held that the right thing to do is whatever creates the benefit for most. And I guess our practice is usually a compromise between these two views. The World Medical Association issued an updated text on organ donation in 2017, and there are some points that could be worth noting. First, flexibility of the national definitions of death is granted in this statement by the World Medical Association. Then written protocols is required, and this creates accountability, acknowledging the need for trust to maintain transplant medicine. And next, the end of life, and the transplant teams should be strictly separated, again, to ensure trust. The donor's wishes should be respected, but this may be complicated, particularly in cases where the donor's wishes are in conflict with the wishes of the next of kin, or maybe even public sentiment. Here's an important point from the statement: death must be by natural causes, which specifically excludes executed prisoners, and it may also make donation after assisted suicide problematic. Finally, there should be no coercion, and organ sale, organs for money, may be thought of as an example of such coercion. The Declaration of Istanbul of 2018 is ratified by most countries that have an organ transplant program, and this specifically prohibits organ trade and transplant tourism. An illustratory example of the dilemmas of organ donation is the donation after circulatory determination of death, the DCD. And in my view, there are three main problems with DCD. First, the intervention before death. A cannulation or a medication to prepare for donation may by some be perceived to interfere in the process of death, or maybe reduce the still living patient to a means to an end. And it would certainly require consent. Second, after the circulatory arrest and the appropriate standby time of 5 or maybe 10 minutes, some would still say that there is a possibility of cerebral resuscitation, which is why, as I said, DCD is not allowed in Germany. And third, when the organs are recirculated to avoid warm ischemia, the blocking of cerebral circulation has been criticized, as for instance by the American College of Physicians, who even described it as to make someone dead. On this slide, you see a table showing on the left, in the left column, the total number of donors in different countries, and you can see that there is great variation between countries. On the right side of this, you can see the rates of thoracic organ DCD, and you can pick your favorite country and see that there are great differences in this practice. Regarding research and privacy in organ donation, I could find no clear rules regarding the research on donors. I know it's often presumed that if there is consent for donation, there's also consent for research. And at least that's how it's been practiced in my country. privacy in transplant is interesting because traceability is mandatory. And this means that there are at least 2 individuals involved, and you must ask whose privacy is at stake. So in summary, I would like to emphasize that organ transplantation is a possibility to do miracles, but it does also create a potential to do harm that goes beyond the individual donor and recipient. So we have to balance the harm of not utilizing organs with the possible harm to the donor and also with the possible harm to future donations and patients who are in need of organ transplants if trust in transplant medicine is eroded. And with that, I thank you very much for your attention.
Thank you so much, Dr. Holm. You reviewing this framework and providing this international perspective is so important. I wanted to introduce our next speaker, Julien Fessler. He's an anesthesiologist and pain management specialist from Foch Lung Transplant Group in Paris, France. Dr. Fessler, welcome to the program. I'm sorry, Julien, you're muted.
Mute. Good. And let me share the screen now. Okay, can you see my presentation? Yes.
Yep, we good.
Perfect. Let's go. So yeah, thank you very much, Pablo, for this nice introduction. And I will talk to you today about the checklist approach to donor optimization in the ICU. Oops. I do not have any conflict of interest regarding this. But first, I would like to introduce some physiopathological context to understand a little bit more all the challenge for the ICU. The brain death storm is a phenomenon that starts with the increased intracranial pressure that leads to a phenomenon called also Cushing response, which is a sympathetic storm leading to affect some organs such as the heart, with an increase of release of catecholamine leading to arrhythmia, bradycardia, tachycardia, and in some situations, a takotsubo. But also, due to the neural damage, it will have a systemic inflammation, major systemic inflammation, creating some lesions to the organs we want to retrieve. And that's something that we can observe here in this very nice study with rats, well, where they look for the heart injury, comparing living donors to brain death donors, and they also look at the impact of the complement and the inflammation. And they observed that the biomarkers of heart injury was more important in the brain death donors, and these lesions were due to the complement and the inflammation, because when it was stopped in this knockout rats, they didn't have such lesions. So all the ICU challenge will need to protect the organs and will protect the hemodynamic management, maintaining an adequate organ perfusion, ensuring a lung protective ventilation strategy, and also all the disturbance of the endocrine management, such as the diabetes insipidus, the thyroid hormone, the corticosteroids due to this inflammation, and well, other management more non-so specific to the ICU. So let's start with the hemodynamic management and the maintaining of the perfusion. And there are recent ISHLT guidelines, consensus statements that guide us a little bit to help to improve the quality of the donors. There are still some conflicting or debatable aspects that are recommended that literature maybe would say things differently. And let's have a look. It says first that we should adjust the volume fluid that we give to the patient to the central venous pressure, the CVP. That's quite strange when we do ICU, because I don't think that's something very used in the ICU anymore. And another aspect of the hemodynamic management is the use of vasopressor to maintain a mean arterial pressure above 60. First, using vasopressin, which is a very North American strategy, but well, why not? But dopamine, it's something very also debatable. So first, I would like to share with you this very interesting pedagogical article point of view to discuss the pros and the cons of the use of central venous pressure to guide fluid management. And yes, we can use a CVP in extreme values. It could be reliable. When a patient has a very, very low CVP, below 6, we can be confident that the fluid will probably improve the cardiac output, because all the issue is to improve the cardiac output. And when the CVP is very high, above 15, we can be confident that probably to fill the patient won't be useful. But in between, there are too many factors that influence the interpretation of the CVP that makes that it's not a reliable tool that we shouldn't use in the ICU. And what should we use? We should use dynamic indicators of fluid responsiveness, such as that's a study, for example, in brain death donor, the only study I found in literature looking for the efficacy of dynamic factors. And they use a dilute cardiac output monitor called LITCO. They injected lithium in the central line and they censored the concentration into the arterial line. And doing some correlation with the continuous arterial waveform, they could have a continuous approach of the cardiac output and then know if the fluid challenge had an impact and it was positive, and if we should follow filling the patient. So that's the flow chart. They enroll patient and then they look how many organs they could transplant. And at the end, it was non-significant between groups, as you can see here. It wasn't conclusive. But even if it's what is recommended, it was not. The study was negative because of logistical issues. 76% of the donor randomized in the group of intervention did not receive the proper intervention due to logistical problems. Because these kind of devices are the gold standard, are what we should use, but it's true that they are difficult to use. So what could be the other option? The other option are the echocardiography, and echocardiography is widely used in the ICU. And the American guidelines for donors management in the ICU recommend the use of echocardiography for assess the cardiac function. It's more the cardiologist's point of view to assess if the heart is suitable for a donation, but not so much for the ICU point of view. But in the ICU point of view, it's a very valuable tool to assess the hemodynamic, well, the macro circulation, because in addition to that, we also need to use other kind of tool for micro circulation, such as the SVO2 or blood-like level, or the recoloring filling time. Well, once we've said that, what kind of fluid should we give? There are no study in donors, but there are a very interesting study in recipients for kidney transplantation. And they compare the consequences of filling the patient with normal saline compared to lactate ringer. And it's maybe counterintuitive, and maybe we would believe that normal saline will increase less the potassium because it doesn't contain potassium compared to lactate ringer, but normal saline increase the metabolic acidosis, which may have some consequences, and at least it increased hyperkalemia. So we should better use balanced crystalloids and hopefully isotonics. Then let's follow with the vasopressor. Okay, vasopressin, why not? Very North American. But dopamine, well, that was one of the first studies, a retrospective cohort from the last century, where they found that patients that received dopamine had a better kidney outcome after a kidney transplantation, a kidney function after a kidney transplantation. It wasn't really specified, it was used as a preference vasopressor, but it was just mentioned that the patient in their record received dopamine. So maybe as a medication, a specific medication, but not as a vasopressor. So the same team performed a randomized controlled trial internationally, and they randomized both the donors either having dopamine as a drug or not, or placebo, but still they maintain the same objective of blood pressure using vasopressor and using norepinephrine. But yes, they found that, they found that patient in the dopamine group, so patients receiving dopamine not as a vasopressor but as a medication, had less dialysis and less repeated dialysis, even though it didn't change the graft survival and the patient survival or the rejection. And that's what we can see. No, the cumulative probability of allograft survival was not different between groups. But well, the question we have still is, what's about dopamine as a vasopressor? And that's the study that made reference in the world of the ICU is a New England Journal of Medicine article from 2010 that compared dopamine to norepinephrine in the treatment of shock. Of course, it was not specifically to donor, but they looked the difference regarding death for the patients. And they didn't find any statistical difference, even though we have the impression, but it's an impression that norepinephrine looks better, but that's not interesting. What is interesting from this article is the details. And if we look in the dopamine group, we find that they had more open label vasopressor as a rescue than norepinephrine. And well, that's vasopressor not needed. And so they did need at the end more, and it was statistically different. And so they had more rescue with norepinephrine than norepinephrine group. But still, the most important part of the study is the adverse events. And they were a very important difference, twice arrhythmias, but not so much atrial fibrillation, yes it was, but also twice ventricular fibrillation. And indeed, in the cardiogenic subgroup, there were an increased risk of death in the dopamine group compared to norepinephrine. So from this study, it was totally avoided to give dopamine in the setting of cardiac shock, and comparing norepinephrine to dopamine, it was as effective but less dangerous. And finally, to finish the debate about dopamine, that's the guideline from the European Society of Intensive Care Medicine. And the consensus says that dopamine is not an inotrope. It gives more arrhythmias. So it may be used as a vasopressor, but it should never be used as an inotrope. And well, let's follow to the guidelines and look for the Surviving Sepsis campaign from 2021. That's are maybe the big rules to the usual shock, of course, septic, but also to the other kind of shocks. And they recommend the use of dynamic measure to give fluid resuscitation, as we talked earlier, to use microcirculation parameters such as serum lactate level and capillary refill time. And they recommend the mean arterial pressure of 65. Then, as a vasopressor, they recommend first norepinephrine as a first-line agent, the second vasopressin, and third epinephrine. Dopamine is not there. Well, yes, it is in the remarks. In the setting where norepinephrine is not available, epinephrine neither, or dopamine can be used as an epinephrine, or dopamine could be used as an alternative. So yes, Surviving Sepsis campaign, we think that dopamine is an alternative to norepinephrine in developing country where, of course, lung and heart transplantation are not possible. So we should remove that from our guidelines. Now, let's look now for the respiratory management and what is protective ventilation. Protective ventilation is to target the tidal volume a little bit lower than what used to be before, 6 to 8 milliliters per kilo, adjusted to weight, but based on the heights. Well, it's quite complicated, but it's ICU cuisine. So just to say that it's low tidal volume, high level of PEEP, and here says that the peak airway pressure should be below 35. But again, that's strange. Why peak airway pressure? What is the difference between peak airway pressure and other kind of pressure? Well, we'll see that a little bit further. But first, let's look why we should be protective. That's a JAMA from, again, 2010. There were a lot of work about donors at this period of the history. The authors randomized the donors into groups, either conventional ventilation, either protective ventilation, and the primary outcome was the quantity of the number of lung eligible for transplantation. They planned to include 200 patients, but due to economical reasons, they had to interrupt the study at 59 per group. So the primary outcome was the lung harvested, and we found that there were twice transplantation in the protective group compared to the conventional group. And what is conventional? Conventional was a high tidal volume, 10 to 12 milliliter per kilo predicted body weight based on the height, a low level of PEEP, but still a PEEP, and a test made disconnecting the ventilator and the airway suction, opening the circuits. Whereas protective ventilation strategy was done using low volume tidal volume and high level of PEEP, and with a closed circuit for the airway suction and also for the apnea test. And then the American guidelines recommend, after this study, the use of the plateau pressure, monitoring the plateau pressure below 30 and not 35 of peak pressure. So let's have a look. So that's just the aspect of the volume-induced lung injury. So the pressure, I will maybe talk a little bit slower now because it's very important to understand. On the right side, you see the peak pressure. The peak pressure englobes everything. All the energy we need to move the air from the machine to the end of the lung, means the alveoli, and it includes the resistance of the airway, the resistance to flow, but then also the resistance needed to maintain the alveoli open, means the alveolar compliance, but maybe the transthoracic compliance, and it includes also the PEEP. Now, let's go a little bit further. So plateau pressure is the pressure, the constraint needed to maintain the alveoli open. And we decided after the RDS consensus, the Berlin consensus, 10 years ago, more than 10 years ago, that 30 was probably the average, the limit we should not pass to avoid the volotraumatism and the barotraumatism, mostly the barotraumatism. The 30 centimeters of water of plateau pressure to maintain the alveoli open. If we go further, we will have lesions. It's just to maintain the alveoli open. But then there are another pressure we should know in the definition. It's the plateau pressure minus the PEEP, and it's this pressure is the real motor pressure needed to maintain the alveoli open. And that's the evolution of the concept of lung protection. So we went at the beginning from high to low tidal volume, from low PEEP to high PEEP, maintaining the lowest plateau pressure. But then we went further and much further with the COVID epidemic, with the understanding of the driving pressure. So this driving pressure is the strains to maintain the alveoli, and it's what is causing the lesions. Sorry. So what says the surviving sepsis campaign? Again, low tidal volume, 6 milliliter per kilo, the plateau pressure and not the peak, and higher PEP. So we are not so different, just a slight difference about what kind of pressure we should monitor. Now, changing a little bit and looking for the endocrine management. Why is it important? Well, it's important because there's something in the brain very important, which is crushed with the intracranial pressure, and which is the pituitary gland. And the posterior part is responsible of the synthesis of the antidiuretic hormones. And when we don't have antidiuretic hormone, the patient develop a central diabetes insipidus, leading to an increase, disadapted and increased urine output, leading to hypernatremia and a high serum osmolality, and of course, because of the urine output, an inappropriate diluted urine with a low osmolality of the urine. It is very easy to treat, but it's very important to diagnose it. It's treated using vasopressin, 1 to 4 microgram bolus, plus 1 to 2 microgram every 6 hours. And then what is recommended in the American Society and also in the ISHLT guidelines is to use vasopressin in case of associated hypotension with diabetes insipidus, because vasopressin has both effects of vasoconstriction and the antidiuretic hormone use targeting the V1 and V2 receptors. Well, let's go a little bit further, and there also it says that we should give methylprednisolone 15 milligram per kilo bolus. And in case of an abnormal echo and unstable hemodynamic, use T3 thyroid hormones infusion. What says the literature? Well, that's the latest meta-analysis regarding the use of corticosteroids to decrease the inflammation. And there's no more successful donation of organ. There are no less acute graft rejection at 3 months, and there are not less graft dysfunction. It's non-significant. So the level of evidence is very low. Well, there's no evidence to support the use of steroids, even though it would maybe decrease the inflammatory cascade we discussed at the beginning due to the brain death. But be careful with the hyperglycemic control. So we have to be very careful then with the unbalance of the blood sugar levels. And now, regarding thyroid hormone administration, similarly to corticoids, there's no evidence in the literature, no improved our cardiac index or less inotropic agents. Well, so now let's follow to the more standard aspects. Well, not so standard, because temperature is very important. It's very important to make the diagnosis of brain death under normothermia. And it's difficult to maintain normothermia in brain death because there are lack of shearing, there are peripheral vasodilation, and a decreased metabolic rate. So we have to be very aggressive warming the patients. Blood and transfusion and coagulation management. Blood transfusion, the threshold is more a restricted threshold of 7 grams per deciliter compared to more liberal, but that's the guidelines are based on non-brain death donors in general population on the ICU. But there are very interesting study, and that's a study from another team in Paris where they found that there was a link between blood transfusion in the donor and primary graft dysfunction in the recipient. In the second study from the Duke University, they found there were a link with massive transfusion in the donor and death in the recipient. Concerning the thromboprophylaxis, we should give low molecular weight heparin, but then sepsis surviving campaign suggests against the use of mechanical thromboprophylaxis in addition to pharmacology prophylaxis. And what says the European guideline for the perioperative? That's perioperative. Well, they recommend against the routine use of graduated compression stockings, and they recommend more the use of intermittent pneumatic compression than the compression stockings. And in case of no use of pharmacological thromboprophylaxis, they still don't recommend the use of socks. And finally, infections. Infection and sepsis is not a contraindication to donation, but the appropriate antibiotic should be performed at least for 48 hours before the procurement. But it's very important then to have a good communication between the donor team and the recipient team, then to adjust the prophylactic, the antibioprophylaxis, and the antibiotherapy in the recipients. So, in conclusion, strange things in these latest guidelines. Maybe a little bit old because the use of a target of a mean arterial blood pressure of 60 and the CDP comes from the river study of the Goldenhour published in 2001 in the New England. But then the sepsis surviving campaign has evolved a little bit, and maybe we should follow them a little bit. That's a checklist. Well, the peak pressure in the ventilation, please no. It's the plateau pressure that we should target. CVP, please no. And then the more strange thing I found in this guideline is that if a are needed, consider pulmonary artery and cardiac output monitoring and add dopamine. So it looks like dopamine is an inotrope. No, it's a lapsus, and they wanted to say dobutamine because dobutamine, yes, is an inotrope, but please, dopamine should never be considered as an inotrope. And then anti-embolic stocking, well, it's very debated in the other society guidelines. So what's the take-home message? Well, maybe follow other kind of guidelines, surviving sepsis campaign, but adapted to the population, because donors have a huge inflammatory and catecholaminergic storm that could lead to central diabetes insipidus due to the compression of the pituitary gland. And well, we should be protective to all the organs, but such as all the ICU therapy. Thank you. Well, that's just to say that PA ratio should be interpreted very consciously depending on the arteriovenous difference and the shunt, because it could vary very much depending on the FeO2. Thank you very much.
Thank you, Dr. Fessler. Thank you for reviewing the current guidelines of the society and also providing some framework from what is published in the literature regarding sepsis and ARDS. I wanted to introduce our last speaker, Dr. Stephanie Chan. She's an assistant professor of cardiothoracic surgery and the surgical director of the lung transplant program at NYU Langone Health in New York, the United States. Welcome, Dr. Chan.
Thank you so much for having me. Let me just get this shared. All right. So today I'm going to talk about the role for centralized donor facilities. In terms of disclosures, I have no financial disclosures, but I am on the Live On New York Medical Advisory Board. And just the outline for today, we're going to talk about the different donor models, some outcomes from a centralized donor facility, and then newer models and outcomes that have changed in recent times. In terms of the different donor models, I think everyone's very familiar with this. So the potential donor comes into any hospital, and when they pass and are pronounced brain dead, the donor management occurs there in conjunction with the OPO representative and the intensivist there at the hospital. And then all of the surgery teams fly to that hospital for procurement. In terms of traditional donor management, it does rely heavily on donor hospital resources. And so most of these little hospitals at best manage 1 to 2 donors per year, which does lead to poor donor management despite the OPO being involved, just due to lack of experience on the hospital side. There's also inexperienced anesthesia and OR staff, which decreases OR efficiency by a lot, which I'm sure every surgeon here has experienced. And there's decreased organ optimization with lost transplantable organs. Also, some of these small hospitals may not have significant advanced diagnostics. They might not have a cardiac cath suite or other things like that. And then there's resource competition. So they are prioritizing all of their other patients. So there's delay in tests and there's delay in the operating room. So many times all of the procurements are the last case of the day after all elective cases are done. In terms of a solution for all of this, we kind of came up with a centralized donor facility. Someone came up with this. And so the first one occurred in 2001 in Missouri called Mid-America Transplant Center. And the goals were to get more and better organs. And it was basically to increase the quality of organs, increase the quantity, and then have just a one-stop full service recovery center. So what happens now in Missouri and at some other places in the US is there's a donor, and once the donor is declared brain dead at the hospital, they're actually transferred to a donor facility. So in Missouri, it is a freestanding facility with all of its own equipment and OR, and then it's managed by the intensivists and nurses there, and the procurement happens in their own OR suite. In terms of the resources of this, the facility manages an extensive number of donors per year, and they have a dedicated intensivist and ICU staff. And then anesthesia and OR, the only thing that they do is procurement. So they're very familiar with everything. And so it's just very smooth if you've ever actually gone to a procurement at one of these areas. And resources are all on site. So there's on-site ORs, tissue recovery rooms, cardiac cath, CT scanners, and labs. in addition to the ICU and all of that. And there's no competition for donor OR time. So most of these procurements happen during daytime and can allow for a first start transplant, which is, again, very rare in the US. And it can cause decreased travel and decreased cost, which I'll go over a little later. But for the travel, these facilities are located close to the main hospitals at transplant. So instead of having to fly out to little hospitals, they just drive down the street. And in 2021, there were 12 of these facilities in the US. In terms of donor facility outcomes, one main thing is the OR time. So this was a paper published in 2011, and it looks at the short-term outcomes for day and nighttime lung transplant. And here you can see in the graph that daytime is the black and nighttime is the blue. And the mortality is higher in the nighttime group. And if you look at lung transplantation at 90 days, which is highlighted in the red, the unadjusted mortality is 1% higher in the nighttime group, and it was significant. Looking at a more long-term thing, WashU actually looked at 5-year survival of daytime versus nighttime. And here you can see that at 5 years, overall survival is 72% with a daytime transplants versus 64% at nighttime. And this actually also affects BOS-free survival. So here there's another 8% difference where at 5 years, there's a 32% BOS-free survival rate, so higher in daytime compared to 24% at nighttime. So that is something that is beneficial from these specialized donor facilities. Another thing is the ability to implement change. So here in 2008, Mid-America Transplant actually implemented a lung-focused resuscitation. This chart here, the details are less important because we just heard all about it. But the more important thing is they were able to institute this and do this on every single donor. So if you look at this chart is looking at the black is the percent utilized at Mid-America Transplant, the gray is the percent of lung utilization nationally, and the red arrow shows the year in which the change occurred. And you can see that pre-change, we were a little bit better than national average, but not much, and some years worse. After the change, you can see there's a huge difference between the lung utilization rate between the localized donor center and the national rate. So lung utilization went up from 19.8% to 33.9%. And the initial PO2 of all of these utilized lungs was actually lower. So it was 267 before the change and 223 afterwards, just suggesting better medical management of these organs and increased utilization. And this did not affect other organ procurement rates, and they had the same rate of implantation of the lungs that were accepted. And then one final thing is it can decrease cost. So looking at liver transplant costs, this was done with WashU and MTS. But if you look at the light gray, that's overall hospital recoveries that WashU did and the cost. And then if you look at the recoveries at the donor center, you can see again, it's significantly less just because everything is streamlined and there's less travel. And then when a different paper just evaluated the cost of observed current thoracic organ cost versus a predicted one if everyone went to the centralized donor facility, you can see that there's $100 million decrease because this is in billions right here. So there's $100 million saved per year if we started going to a central donor facility model. So one issue with this is Mid-America. I love Mid-America Transplant. I know Gary Marklin is on this, and it's a wonderful facility, but I currently work in Manhattan, and there is no space in Manhattan, and the cost for overhead and building something else is astronomical. So we had to come up with a different solution here to kind of optimize donors and increase organs. So what we actually did, I guess, is a modified central donor facility. And so we take the potential donor, and once they are pronounced or going for organ donation, they actually get transferred to a specialized donor hospital. So here it's NYU, and we actually will transfer them in. And then similar to a freestanding facility, we perform all the donor management with the OPO involvement and the procurement here. You can see this is the Live on New York area. So this is includes all of New York City and Long Island, and then some of areas north of New York City as well. And so anyone that is pronounced in this area that is brain dead will actually get transferred to NYU Langone for donor management, unless it is an existing transplant facility. And so that's been our work stream right now. And then some other non-brain dead donors will also come here. In terms of the specialized donor hospital, so one of the pros is the families are present for the donor walk and can come to the operating room with their family. MTS is amazing, but we have all of the specialists here. So if there is an NG2 bleed causing nasopharyngeal bleeding, we can have ENT come by, or if there is a question of a kidney loss or kidney mass, then nephrology can come by. And so we have all of those consults and resources, and there's no increased operational cost. So there's no overhead for building a freestanding structure. And we already have all of the physicians and the staff here. It also allows for whole body donation and those brain dead studies. So that's what we did for the xenotransplantation with the heart and kidneys that have come out of NYU. And then more recently, for those NRP DCD candidates, they actually get transferred to our facility here as well, just because we are a full hospital, so we can care for them as well. The cons are there is less flexibility with scheduling because we do have our own elective cases, and there's limited bed availability as well. So there are pluses, but definitely drawbacks. Sorry, that's my dog having fun on the couch. Anyway, so in terms of outcomes from a specialized donor hospital, we started this in January of 2021. Here you can see all of the transplants that were done in the calendar year of 2021. But if you look at the purple, which is all of the organ utilization or organ transplanted per donor at NYU, it's 3.05, which is higher than the rest of the live-on areas, which was 2.54. And then for our fiscal year, which started in September of 2022, you can see we got better after our first 8 months of experience. So this is a full calendar year of the number of transplants done, and our organs transplanted per donor actually went up to 3.39. So overall, it is a promising strategy for people that can't have a full standing donor facility. Thank you.
Thank you very much, Dr. Chang. That was perfect. It was a nice way to adapt to the circumstances of a busy city like New York. I think Dr. Fessler is gonna lead a bit of a Q&A that we have now. Not sure how much time we have left, but go ahead, Julien.
Yeah, sorry, I took a little bit too much time. Well, for my presentation, but well, first I would like to ask RS some questions about the ethics, the concrete applicancy of ethics in your team. How do you teach to your learner, to your students all this concept of ethics? That's my first question. And the second question is, do you have help from someone out of the team to help in some difficult situation with families and maybe some member of the staff that may have ethical issues with the donors?
Thank you for that question. The first question about teaching ethics, we have no systematic teaching of ethics, but it's part of the normal internal teaching process for all groups in the hospital. And regarding external forces, we have at the hospital and at every hospital in my country, there's a clinical ethics committee that may be assembled on a short notice to consider complicated cases. And we not infrequently we consult this group, and these are external; these are non-transplant people. So I find that very useful to have these kinds of consultations with an external group in these whenever difficult questions arise. And I guess apart from that, I would like to add that the stance in my country or at our center has often been the soft opt-in model where we try not to offend because we think in the long term to maintain trust in the system may be more important than each individual donation. So a long-term policy, and I think that's paid off pretty well. We have 80% consent rate in our community.
Yeah, thank you. This last point to trust the system is very important, even more important than saving one patient. We'll have time to save it later. and it's important to not lose the candidates. And there's a question. There's a question for Stephanie that they say that is improved organs recovered per donor in this facility due to access or to the management?
Yeah, I think it's a combination of both, but I think a lot of it is management, just because we transplant every organ here as well. So when there's a question, let's say there's a lung, even though I don't have a right blood group or something, they will call us and say, hey, what do we need to do to get this a little bit better so that someone will accept it? And it's just, again, having a facility where everyone knows what they're doing and is a transplant center, I think is different than a very small hospital that has none of these services. And so is a little less driven to provide that sort of care, if that makes sense.
Yeah, I think proving the expertise makes to have better results. Well, there's another question for you. Very interesting, very practical. How often do you encounter residents from relatives to transfer a donor to a centralized donor facility?
So I actually don't interact with any of the donor families. So I have not heard of this. I think most of the time the families are very willing to do it, just because, again, they just they travel with their loved ones, but I'm sure it is an issue. I just haven't seen it.
Thank you. Well, do the other panelists have questions?
I do have one question, since we are over time already, so might as well. Jennifer, you and Stephanie come from two different realities. So what are your thoughts about a centralized facility?
Well, I think Stephanie's presentation was amazing. So, and I think that it's a brilliant way to be able to certainly be able to optimize and deal with donor management. I mean, we can do it going to a small district general hospital where they might not have had a donor in 2 years. So we can see the benefit of all of that. So being able to have it centralized, as you were describing in your presentation, I think is the way forward. I think it's an amazing thing to be able to take on. It can only be beneficial, I think, and which is shown in your data. So I think it's a brilliant thing.
Very nice. Well, we don't really have any more questions from the audience, and I think it's a little bit over 4. So I will say that this concludes the scientific portion of the webinar. Julien and I would like to thank Sue, Lisa, Juliet, and Susie from the ISHLTv. Of course, we would like to thank Caroline Patterson for all her help setting up and designing this webinar. I'd like to thank you, the speakers, for spending your afternoon with us, and we appreciate so much your time and sharing your expertise. And of course, everybody that was able to join us and take the afternoon with us. Thank you very much for being here. Julien, I don't know if you want to say something else to close.
Yeah, just France won the match.
Oh,
So we'll play against Argentina. We'll be very pleased.
well, there you go. It's gonna be fun.
Thank you very much.
All
Thank
right,
you to
everybody.
all. To you all.
Have a good afternoon.
Thank you.
Bye.